Good evening to everybody and welcome to the second webinar of the ESGE of 2024. It is my great pleasure to stay here with you and to discuss a very hot topic. We will discuss about POEM and its utility as a first-line therapy and treatment for both esophageal and gastric motility disorders. You know that POEM was first done in humans by Professor Haruhi Inoue from Tokyo. And then from that point, it was more than 10 years ago, we started changing a little bit the indication and moving not only for the esophagus, but also moving the gastric side and also in Zenkers. And we are here discussing how to use this type of technique, advanced technique. I'm very happy to share this stage with some great presenters. So we have Professor Jan Martínek from Czech Republic. And then from Germany, from Augsburg, we have Dr. Sandra Nagl, that unfortunately she can't be with us and she recorded her presentation. But we have Professor Helmut Messmann that will join us and we'll have a great discussion together. I will remember to all of you that you can use the Q&A to make your question, and we will read and we will try to discuss based on the comments and questions that you'll make. So let's start with the first presenter, that again is Professor Jan Martínek from the Hepatogastroenterological Department in Prague, and he will talk about the new developments and indication for GPOEM. Jan, the stage is yours.
My task is to describe the GPOEM as a first-line therapy for gastroparesis. Yes, I have nothing to declare. As you may know, that first gastric POEM or per oral endoscopic pyloromyotomy was performed and published in 2013 by Moen Kashab from Baltimore, and we performed the first GPOEM in 2015 in a patient suffering from severe gastroparesis. Here she got to newspaper that she has been starving, and the GPOEM had really quite good effect. But should I answer the question, should GPOEM be used as a first-line treatment for gastroparesis? My answer is no, because we should always start with dietary measures and drugs. But if this does not work, we should consider GPOEM, because we now have quite good data about the efficacy of GPOEM in patients suffering from gastroparesis. Let's start. I will describe 3 cases. The first case is a female, 27 years, complaining of nausea, retching, fullness, inability to finish the normal-sized meal. Her symptom index was 1.36. It means not very severe symptomatology, because the maximum is 5 and she had only 1.36, and quality of life 93. The maximum is 150. Scintigraphy showed retention at 4 hours 12%. The normal value is 10%. It means not very severe retention. There were no effect of conservative treatment, and she was diagnosed with idiopathic gastroparesis. We measured, because we were not sure about GPOEM in this patient, we performed the endoflip measurement. And as you can see here on the table on the right corner, the distensibility before or baseline distensibility was 2.3 when the balloon was filled with 30 milliliters, 2.1 with 40 milliliters, and 1.2 with 50 milliliters. It means severe pylorospasm. Based on this measurement, we decided to perform GPOEM, and you see the video of pyloromyotomy by using TT knife, and sometimes we encounter fibrosis when performing myotomy here, and sometimes you will see in some other videos we experience more bleeding compared to esophageal POEM, and we really try to cut the whole muscle up to the serosa. Here you see the minor bleeding, which we can coagulate or treat by using the knife. We check the pylorus during myotomy, and if necessary, we use a flip after the procedure. And in this patient, we closed the incision with flips, and you see the nice view of a myotomy site at 6 o'clock. It's a really well visible. And what was the result after GPOM? You see that before the distensibility was low, 2.1, and after at the same filling volume balloon was 12.9. So increase, tremendous increase in terms of distensibility. And symptoms, her asymptomatic index was after GPOM 0. Quality of life 172, much better. She told me, GPOM has changed my life. It's 180 degrees better, turning point. Thank you very much. Let's look at the case number 2. It is a patient, and you see from endoscopic video that there was a severe gastric retention, food residues everywhere, and the pylorus endoscopically it looked normal. And there is one thing to remember. This patient suffered from achalasia. This patient was offered laparoscopic myotomy or POEM. But because the POEM was not available at the city or in a city she is living, she decided not to travel to Prague, but to undergo laparoscopic myotomy with partial fundoplication in this city. 1 month after laparoscopic myotomy, her dysphagia improved, but she started feeling fullness, early satiety, nausea, further exore, and there were no clinical improvement with prokinetics. As you see, scintigraphy showed 37% retention at 4 hours. It means severe gastroparesis. So we offered her GPOM. First, we measured endoflip, as you can see here. And the values I will show you later. And in this second case, I will go step by step how we do GPOM. The second step is a submucosal injection 3 to 5 centimeters from the pylorus, usually greater curvature. Then we perform transversal incision. And after some dissection, we enter the submucosal space. The aim during GPOM is to find this image, the pyloric ring or the pylorus. Here you see the gentle preparation, and here you see clearly really spastic pylorus. More pylorus is spastic, more difficulties to find it. And here we start the myotomy. Sometimes I perform underwater myotomy. And here you see the continuation of myotomy. The length of myotomy is usually 2 to 3 centimeters, and sometimes it's not rare to experience bleeding, as you will see in a few seconds. Sometimes the bleeding can be really difficult to stop, to manage, because after first coagulation there is a relapse and recurrence, and so it's, you see here, it took more than 10 minutes to stop this bleeding, even though it was not hemodynamically significant. At the end, this is still, we try to stop the bleeding to coagulate the vessels. You see the small perforation on the left side, but there were no symptoms, and the myotomy was quite, I was satisfied with myotomy. You see the bleeding again. Then we close the incision by using a suture device. And this happened, this procedure was done in January this year, so 1 month ago. And if you see the endoflip measurement before procedure, the distensibility was 6 at 40 milliliters filling volume. It means pylorospasm. Just after the procedure, we are going to measure again her pylorus 3 months after the procedure, but just after myotomy, the distensibility was only 8, so not very significant increase in distensibility. And I called the patient yesterday, and 1 month after the procedure, she is not feeling much better. She's not worse, but she's not improved. The question to me, we will wait 2 other months, whether the myotomy was sufficient, because this we will see when performing another endoflip in 2 months from now. But it could be the case, for example, that the myotomy was not really effective, or there is residual pylorospasm. And there is a study showing that clinical success was higher in patients who received double myotomy instead of single myotomy, what we consider our standard. So this was the second case, GPOM, post-surgical gastroparesis, so far no effect. And the third case, this was a lady suffering from post-surgical gastroparesis. We performed first GPOM 2018. The first operations, first surgery was fundoplication, but there was no effect of this procedure. At that time, we didn't have endoflip in 2018. Later, we bought endoflip. And as you can see on images on the right side, we really thought this patient is kind of crazy patient, because she visited emergency department every 2 weeks. She complained of nausea, vomiting, typical gastroparesis symptoms. But then we felt during endoscopy that the pylorus still looked spastic. We performed endoflip measurement, and as you see, the distensibility was 3.7. It means low, still pylorospasm. So we decided to offer her re-GPOM, our first re-GPOM. We used the other side, and you see the pylorus was not at 6 o'clock, but rather at 9 o'clock. And after this procedure, the symptoms improved significantly, no residual symptoms. Scintigraphy improved, not normalized, but improved significantly. And since then, she never visited emergency department. So really good effect of a re-GPOM. Teaching point that the first GPOM was not either good, well done, or single myotomy was not sufficient to relieve the pylorospasm. So I presented to you 3 cases. 2 of them had a good effect, one after first GPOM, second after re-GPOM, and 1 case without clinical improvement 1 month after the procedure. So the question is GPOM in patients suffering from gastroparesis better than placebo? And these are pictures from our randomized trial showing that the treatment success at 6 months after GPOM was 70%, compared to 22% in patients receiving sham procedure. And crossover GPOM was effective in 75% in those patients who received sham procedure at the beginning of this trial. So we know that GPOM is better than placebo, but please note that if treatment success was present in 70% of patients, it means that 30% of patients didn't have any treatment or clinical success. And this is very important. If we look at the etiology, the best etiology responding to GPOM was diabetic gastroparesis. You see the treatment success 90% versus 17 placebo. In post-surgical and idiopathic gastroparesis, the differences were lower, numerically somewhat lower, and because our study enrolled only 41 patients, we cannot draw any firm conclusions in terms of post-surgical and idiopathic gastroparesis. Kristina Hugová, our PhD student, and she presented at UEG Week 2023 the long-term results of those patients from this trial. And this graph means that in patients who experience treatment success at the beginning, usually recurrences are rare. So once the GPOM works, recurrence is really rare. How can we predict that GPOM will work? there is no good answer. We don't know. You see the list of predictors which have been published among several studies, but there is no agreement in terms how to predict treatment success or failure with a GPOM. I would say that EndoFlip, which we are using in our daily clinical practice more and more, can help when making decision. As you saw first case, we are not sure about the GPOM, but EndoFlip measurement showed the pylorospasm, and we decided to offer GPOM to this patient based on EndoFlip measurement. Here you see the picture of another patient, value pylorospasm before and no pylorospasm after. But the problem is that we still don't know either normal values of pyloric distensibility in normal subjects. The holy grail is this answer. If there is a gastroparesis with pylorospasm, GPOM could be good option. If there is no pylorospasm, there is no place for GPOM or other pylorus targeted therapies. And EndoFlip seems promising, but not yet ready for standard clinical use. But I am very happy to announce you that in the Czech Republic, we started negotiating with insurance company that EndoFlip should be reimbursed in next or in 2 years from now. And what about, very shortly, 2 other indications for gastric myotomy? There is a study from Christopher Thompson who combined gastroplasty, endoscopic gastroplasty with endoscopic myotomy. The aim is to decrease gastric motility for patients with suffering from obesity. And this other interesting indication is to treat stricture or stenosis after gastric sleeve gastrectomy. And there is this pilot trial and also French group from Marseille. They have also some pilot data showing this, that gastric myotomy in this indication could be good option. So let's summarize that approximately 30 patients will not have symptomatic response after GPOM, and that predictors how to predict treatment success or failure in patients with gastroparesis are not defined. FLIP is under investigation, and to me, it's really promising method. However, if GPOM does not work, there is no harm. This is a very safe procedure. Dumping syndrome is rare. So even though we offer GPOM and there is no success, there is no harm. That's why we can really offer GPOM to all patients suffering from gastroparesis until we have some better selection tool. Of course, patient selection is a subject for further research. And do not forget, when working with patients with gastroparesis, the gastric electrical stimulation, which could be good option for these patients, and combining GPOM with gastric electrical stimulation could also be an option. If you are interested in third space endoscopy, you can still register to this meeting held in Prague. This is hybrid event, so you don't have to come to Prague, which will be held at the end of February. And I think we should perform some bariatric indication for gastric myotomy. Thank you for your attention.
Thank you, Jan. Yeah, you make it very comprehensive to try to understand what are we doing, for which reason and how. I have some questions, so before moving to the other topic, again, I will check all the time the Q&A in case any question are jumping. So we have Arvis that is asking, the second case is possible of damaged vagus nerve during the first esophageal operation. So the question here, because the patient had the myotomy, is the surgical myotomy, so is trying to understand the physiopathology of these gastroparesis. What do you think?
I am sure it's a vagal nerve injury. It's a, I don't know, maybe it occurred during fundoplication rather than during myotomy. But if we speak with patients suffering with achalasia and we describe laparoscopic myotomy as one option, POEM as another option, the advantage of POEM is absence of gastroparesis. There is no risk of gastroparesis at all, never been reported. While in a laparoscopic myotomy with fundoplication, there is even low risk of this severe gastroparesis. And this is, in my view, a good case to demonstrate the advantage of POEM, because we still discuss disadvantage of POEM as a reflux, but risk of gastroparesis after laparoscopic myotomy, this is one argument in favor of POEM. And after this, we experience this case, which is quite severe gastroparesis. We underline as advantage of POEM the absence of risk of development of gastroparesis after POEM. And for sure, Roberta, this was a injury of vagus, yes.
Yeah. And this linked to the second question. So you demonstrated very well that the diabetic gastroparesis is responding much better than the other two forms, the idiopathic and the post-surgical to GPOEM. But what's your comments on why they are responding much better? Can you guess why? I don't know. It was in my mind while you were talking.
This is a very good question. That's why we are preparing, Kristina Hugová is preparing a protocol, pan-European protocol, and you should also be involved in Milan to test in a large group of patients the efficacy of GPOEM in patients which will be separated according to etiology. Diabetic, one study, post-surgical second, idiopathic the third study. My answer would be that it seems that pylorospasm plays more important role in diabetes compared to other etiologies, because this is the only explanation why GPOEM works better in this etiology. Why it is, what is the mechanism, pathophysiology? This is quite complicated issue. Michael Camilleri would be maybe the best to answer, but he would kill us with molecular biology and with cells and inflammatory cells and so on. But there is no doubt that in diabetes, especially in type 1 diabetes, the pylorospasm plays a major role in development of gastroparesis. And in 1986, when pylorospasm was firstly demonstrated by Michael Camilleri, this was the group of patients suffering from diabetes type 1.
Okay, so in this protocol, you will divide and analyze differently type 1 and type 2 diabetes also.
Yes. Yes.
Oh, very good, very good. And we will wait for the results. It's a very good protocol. So we'll move to something more specific from the technical point of view. We still have one question about GPOEM could have a role for delayed gastric emptying post-esophagectomy. In the gastric side, I would say yes, because it's post-surgical, but I will let you answer to this question.
In our study or in several studies, this group of patients, this specific group of patients suffering from gastroparesis or symptoms after gastric pull through after esophagectomy is a special group, but it seems, and we sent the abstract to upcoming both ESGE days and DDW. The first author is Jean-Michel Gonzalez from Marseille, but we also contributed to this big retrospective analysis analyzing the effect of GPOEM in this subgroup of patients suffering from gastroparesis after esophagectomy. It seems that GPOEM is very effective in this group of patients, and I hope that we will publish this retrospective analysis with more than 100 patients included. So visit ESGE days and visit DDW, and at both meetings the results will be available. To be honest, there is no paper, there's no publication so far describing GPOEM in this group of patients, but it will come soon. And of course, there is a need to to do a prospective trial, and there is a good question whether pyloroplasty should be the standard part of esophagectomy or not, because it is quite we see these gastroparesis very often, and pyloroplasty is still not standard part of esophagectomy, and this is maybe some question for our surgeons.
Yeah, it's a very good point. They are adding in some centers, not always after fund application for flax, but not yet for esophagectomy.
Yeah.
So we have some other question, very technical. So one is, does the length of the tunnel and the myotomy varies with the severity of gastroparesis in GPOM?
No, we keep our myotomy length 2 to 3 centimeters, maximum 3, because we don't want to compromise gastric motility. And by performing myotomy, we can influence negatively the gastric motility, what we don't want to do in patients suffering from gastroparesis. And the length of tunnel, we try to do, once we have the suture device, Apollo suture device, we can really do short tunnels, because in case of problems with closure when using clips, we have some secure or rescue suture or closure method. If you have only clips available and you don't have Apollo or Ovesco, for example, I would recommend to do longer tunnel, 5 centimeters, to be sure that your myotomy will always be protected by healthy mucosa.
It's a very good point, trying to avoid complication, because one of the other question was about complication, and is what happened with a small perforation? Should we use clip or it will close alone? So I would say that it's not a clear question, because it depends on what you mean with perforation. If you have a small perforation, as you shown in the video, inside the tunnel, you will be covered by your mucosa, so it's not a full thickness perforation. But anyway, I will let you comment.
Right. Sometimes it could happen, the small perforations in a serosa, especially when we try to stop bleeding. These perforations could be symptomatic, because sometimes the bile or gastric juice can irritate the peritoneum. We never got serious adverse events, but we experienced some patients with some pain or localized pain, which was necessary to treat by analgetics when these small perforations occur, but it's not always the rule. We don't close these small perforations, because if using clips in this, the muscle is quite hard, we would make the situation worse. So we don't treat it. We must safely close the incision to assure that mucosa is covering the myotomy site, but these small perforations we don't treat.
Okay. And then I have a personal question. You know that in the esophageal poem, you extend your myotomy in the gastric side just to be sure to have no incomplete myotomy at all. But here in the poem, you are phasing and focusing only on the ring of the pylorus. We don't extend at all in the bulb a little bit.
Yes, a little bit, but in terms of 2-3 millimeters. So we don't extend the myotomy into the duodenal bulb in terms of centimeters, but rather I try really to cut the whole pylorus, but you don't have to extend the myotomy to the duodenal bulb. On the contrary, by doing this, you can increase the risk of duodenal perforation, which we try to avoid. So and our results show, when performing flip after GPOM, that usually we are quite effective in increasing the sensibility. So I don't think it's necessary to do something like we do in esophagus.
Okay, a few more questions and then we'll move to the esophageal side. The question that is coming from the Q&A is about training. And specifically, they're asking if they have some ESGE curricula for GPOM, but I would extend this question to you saying, Do you think that it's important to be already able to perform and mastering esophageal poem before moving to G poem, or should and could we start directly from G poem in case we have patient and we have the chance and the ability to?
Yeah, ESG is now working at a poem curriculum, so I think the paper should be or the main ideas should be presented in Berlin during ESG days, and the paper should be ready within few months. Because now there is a voting process. It concerns only esophageal poem, how to train for esophageal poems. I agree definitely with you, Roberta, that if you want to do G poem, you should be really trained and experienced in esophageal poem, because to me, G poem is still more challenging compared to esophageal poem, because the muscle is always different, sometimes more fibrosis, more bleeding. The closure is an issue. It's not as easy as in the esophagus, and to get the orientation and to get the really good depth of myotomy is even after 80 G poems I have done so far, it's more challenging procedure than esophageal poem. So I completely agree, and there is no ESG curriculum how to train for G poem. It's maybe good idea to do something like that. But you should know, the endoscopist should know poem, esophageal poem, right?
Completely agree. And the very last comments in the Q&A chat is, please provide a link for the Prague meeting. So if you want, we can share later with all of them the link for your meeting. Thank you,
Yes.
Jan. And we will move to the second presenter. Is a recorded video from Sandra. And her topic is Sandra Nagl from Germany, from Augsburg. We are here with us. Helmut, are you here with us?
Yeah, I'm here. I'm here.
Oh, hello, Professor.
Hi.
Very happy to have you here.
Hi,
So
Roberta.
we'll see the video of Sandra and how I do esophageal poem and Z poem, and then we'll make some comments. And I hope also question from the Q&A.
Hello everyone, my name is Sandra Nagl. I'm a gastrologist at the University Hospital in Augsburg in Germany, and I'm very happy to talk about how do I do esophageal poem and set poem, and I'm also going to talk about how to perform D poem. So before we start poem, we have to know about the indications for poem. Several studies in the last years have shown excellent clinical efficacy rates for poem for achalasia type 1 to 3, and also in comparison to greater pneumatic dilatation and laparoscopic calloid myotomy. So for achalasia type 1 to 3, poem has developed as one of the first-line treatment options. And for spastic motility disorders such as check esophagus, there's also data that confirms the efficacy of poem. Limited data so far is available for the distal esophagus spasm. Before we start the poem procedure, we should perform at least 3 diagnostic motilities to confirm the correct indication, EGD to rule out different reasons for dysphagia, esophageal manometry to confirm the underlying motility disorder, and a time-varying esophagogram to get an impression of the anatomy and the dilatation degree. And before we start the pen procedure, we should check the equipment we need. We need a high definition endoscope with water jet irrigation function. We need a submucosal insection solution. There we commonly use a combination of saline and a concentration of blue dye. This is either indigo or methylene blue, which facilitates the identification of vessels and the dissection plane. And then we need a transparent distal cap, preferable a cone-shaped cap, to facilitate the submucosal tunneling. Then we need electrosurgical knife. Traditionally, we use the triangle tip knife that facilitates the hugging of the fibers, usually with a water jet integrated function, because this decreases the procedure time and improves the safety. Then we should have prepared a coagulation forceps in case of bleeding or to be able to pre-coagulate large vessels. And we need low flow CO2 to prevent gas-related complications. And of course, we need to know about the distinct electrosurgery settings we use for different steps of the POEM procedures. The different settings are largely dependent on the brand and the model of the electrosurgical unit, the type of the knife, and of course the operator's preference. The patients need to be intubated, of course, and can be either in a supine or left lateral position, depending on the operator's preference. But it is important that we can clearly distinguish between the anterior and the posterior wall, depending on the patient position. And for clear orientation, we can advance the scope into the stomach to locate the lesser curvature, and then carefully withdraw the scope without altering its orientation to establish a clock face orientation within the esophagus. And then we can identify the anterior wall in a 12 to 2 o'clock position and the posterior wall in a 5 to 7 o'clock position. And while we advance the scope into the stomach, we should also get an impression about the resistance of the lower esophageal sphincters and the gastroesophageal junction. And depending on our decision to go either for an anterior or posterior approach, we inject about 4 to 5 milliliters of saline in a combination with blue dye with a needle into the submucosal plane until we have a nice cushion of the submucosa. And then we start the mucosal incision approximately 2 to 3 centimeters to the myotomy starting point. And we perform the mucosal incision by inserting the knife into the submucosal plane using a cutting mode, and then we extend the incision about 2 centimeters in the longitudinal axle from cranial to caudal, and we try to avoid areas with thick submucosal vessels or severe inflammation. And in order to get an easier access probably to the submucosal tunnel, we can also perform an L-like cut. That means that we perform a short cut, horizontal cut at the distal part of the longitudinal cut. Then to enter the submucosal tunnel, we first have to carefully trim the caudal and lateral edges of the incision to widen the tunnel opening and to facilitate the entry. And the conal cape facilitates the access to the dissection of the tunnel. And once we enter the tunnel, we dissect the submucosal fibers close to the muscle layer to ensure the mucosal layer is not injured and to avoid any thermal injury of the mucosa. Superficial injury to the muscle layer is normally of little consequence, since the dissection of the muscle will be performed anyway during the myotomy. And the dissection with an internal should be performed using a sequential injection of saline and blue dye, preferably using a knife with jet function. And usually we perform the dissection by loading the submucosal fibers and advancing the dissection from one side to the other and pushing the endoscope gently against the advancing submucosa. Muscularis propria interface, and we extend the submucosal tunnel about 3 centimeters distal of the GE junction to allow a myotomy, which extends 2 to 3 centimeters below the GE junction. And if we find any small vessels, we can coagulate these with the same settings we use for the submucosal dissection. And we should always check the direction of the tunnel by withdrawing the endoscope and always having the muscle layer at the same position. An important step of the POEM procedure is also to cross the GE junction. Therefore, it is important to recognize the GE junction, and there are different possibilities. First, when we approach the GE junction, we see a narrowing of the lumen associated with a resistance to the endoscope passage. When we gently dissect the tunnel further, across the GE junction, it is followed by a sudden increase in the submucosal space. Another option is that before we start the Poem procedure, we can measure the distance between the incisives and the GE junction, although the intraluminal and the intratunnel measurements do not match perfectly. Another option is that we can inject a lot of solution into the submucosal space, and then we go outside the tunnel and can observe a dye-stained bulge below the GE tube. Upon reaching the gastroesophageal junction, we can also identify large perforating vessels, and we can also observe an increased vascularity and presence of the so-called spindle-shaped veins. Or we can find so-called palisade veins on the mucosal side of the tunnel. Another option to identify the GI junction is with the use of the so-called double scope transillumination technique, where second scope is progressed through the gastric lumen in order to observe in retroflexion the light of the first scope inside the submucosal tunnel, and this can help to identify the GI junction and guide further gastric myotomy. So once we have dissected the submucosal tunnel across the GI junction, we start our myotomy about 2 centimeters below the mucosal incision, and then there are various manners and techniques how to perform the myotomy. Most commonly, we perform the myotomy in a cranial to caudal manner. The knife is held against the muscle and a slow controlled incision is made with sequential single taps on the foot pedal until the knife tip passes through the muscle layer. But especially when we have a very narrow GI junction, we can also perform the myotomy in a caudal to cranial, like in a bottom-up technique. But this is also dependent on the operator's preference. And during myotomy, of course, we have to be careful not to touch the mucosa to prevent thermal injury. And then we can perform 2 different techniques. We can either hook the knife tip between the muscle fibers and cut the muscle fibers while gently pulling the knife towards the mucosal layer. And for this technique, we have to ensure that there is sufficient space between the muscle layer and the mucosa. If there are spasms, like in this case, we just have to wait a few seconds and then we can continue our dissection in the same manner. Or we can apply diathermy with the knife, beginning from the mucosal side of the muscle fibers in a stepway fashion until the desired depth of myotomy is achieved. Then the question is, should we perform anterior or posterior myotomy? And if we remember this illustration, from a pathophysiological point of view, it might make sense to preserve the sling fibers to prevent reflux after POEM. But studies have shown that myotomy can be performed either the anterior, like 12 to 3 o'clock position, or posterior 5 to 7 o'clock side, and has shown comparable results in terms of technical and clinical success, as well as gastroesophageal reflux disease after POEM. And sling fiber preservation POEM has shown differing results in different studies in terms of prevention of GERD. So anterior posterior myotomy can be chosen based on the technical ease, the individual preference, the tortuosity of the esophagus, and prior surgical or endoscopic interventions. The gastric myotomy should be performed 2 to 3 centimeters distal to the GE junction to allow complete disruption of the lower esophageal sphincter, but a longer myotomy length on the gastric side may correlate with increased rates of reflux esophagitis. So what about the length of the tubular myotomy? This depends on the type of achalasia or spastic motility disorder. For type 1 and type 2 achalasia, the myotomy length of 4 to 7 centimeters has been shown equally effective to a myotomy length of more than 7 centimeters, but was associated with a shorter procedure time and with similar rates of adverse events. And for type 3 achalasia or other spastic esophageal motility disorders, the length of the myotomy should be tailored to the length of the spastic segments and correlated with the manometry findings. So in this case, upon slowly withdrawal of the endoscope, we can identify spastic segments, and then we start our submucosal insection and incision just above the most proximal spastic segment. In case of selective myotomy, the aim is to locate the tip of the knife in the intermuscular space between the circular and the longitudinal muscle layer. And here we can identify nicely the longitudinal fibers and the circular muscle fibers, and continue in this process with a cutting line between these two muscle fibers. So full thickness or selective myotomy approaches are both acceptable. In studies, they have shown similar rates of clinical efficacy and adverse events. One study has shown higher incidence of GERD after full thickness myotomy, while another has shown similar incidences, but full thickness myotomy may be performed faster. How can we assess the efficacy of myotomy intraoperatively? There's data that using impedance planimetry technology with endoflip, measuring the distensibility at the GA junction correlates with the clinic efficacy. Also, comparative studies are missing, but this tool can be used in real time and allows adjustment of the myotomy length and depth. And at the end, we can use through the scope clips for the mucosal closure. We start with the most distal part of the mucosotomy and adjust both edges of the mucosal incision and continue to close the mucosotomy by placing an average of about 4 to 6 clips. What about challenging cases such as sigmoid type achalasia? In these cases, additional curved myotomy on the opposite side combined with a short tunnel myotomy to disrupt the LES could be effective and change the course of the curve. And there's also data supporting this approach. And when we perform POEM, we should also know about how to manage and how to prevent adverse events. When we encounter, for example, small vessels during tunneling, these can be treated using coagulation currents, such as spray coagulation. When we encounter larger vessels, up to 1 to 1.5 millimeter in size, these can be pre-treated using the knife, and vessels larger than 1.5 to 2 millimeters should be treated using the coagulation forceps and soft coagulation, but we should use the coagulation current only close to the muscle layer to prevent mucosal injury and subsequent full thickness perforation. In case of a severe bleeding during POEM, which is rare, we can use water irrigation to identify the site of the bleeding, and then of course we need the co-grasper with soft coagulation. How can we prevent mucosal tears? Mucosal tears can have a spectrum between whitening of the overlying mucosa to a full thickness perforation. And it is important that during the POEM procedure and after performing the myotomy, that we confirm the integrity of the mucosa and that we check the mucosa for any injury or perforation. If a mucosal injury occurs, this is most commonly while crossing the GI junction, because there the tunnel narrows at this point. So we should use a lot of submucosal injection to have a sufficient space in the submucosal tunnel, and should perform the dissection close to the muscularis propria. But if we have a mucosal injury, we can either treat it through the scope clips, or if we have a larger one, like in this case, we can close it using the OTSC. When we perform POEM, we use low flow CO2, but still there can be gas-related adverse events. So usually these are clinically silent and disappear spontaneously. The patient should be continuously assessed for abdominal distension, and then if necessary, the procedure should be interrupted to perform needle decompression of a capnoperitoneum. So next, I would like to talk about how to perform DPOEM and what are the differences to conventional POEM. So we can perform DPOEM in case of epiphrenic or other esophageal diverticular. This can occur either with or without achalasia or other motility disorder. And the available data shows so far good clinical efficacy. When we perform DPOEM, we usually start our submucosal incision 2 to 3 centimeters above the diverticular septum and perform the mucosotomy in direction towards the diverticular septum. Then we open the submucosal space on both sides of the diverticular septum, one towards the esophageal side and one towards the diverticular, and extend the submucosal tunnel on the esophageal side about 2 to 3 centimeters below the GI junction. In case we have an achalasia in combination with such an epiphrenic diverticular, it is important not to perform only the myotomy of the septum, but also of the lower esophageal sphincter. And in case we only have an epiphrenic diverticular without achalasia, mostly the distensibility of the GI junction is also impaired due to the diverticular septum close to the GI junction, so the patient also benefits from a myotomy of the LES. So we start our myotomy at the esophageal side and perform the myotomy of the LES first, and then we perform the complete myotomy of the diverticular septum until we reach the bottom of the septum. And then finally, we close the mucosal incision through the scope clips. In case of syncope diverticular, conventional septotomy with different techniques and tools to cut the cricopharyngeal muscle has shown good clinical efficacy, and using the overtubers, this is a very safe procedure with a very low rate of adverse events. But in large prospective studies, recurrence rate were reported in up to 23%. But the technique is repeatable without increasing the risk of adverse events, but incomplete cutting of the septum is considered as one reason for recurrency. So the idea with ZPOEM is to have a technique that allows the complete dissection of the cricopharyngeal muscle. Before we start ZPOEM, the patient needs, of course, intubated. We also use low flow CO2 and a transparent distal cap. And here we can see a syncope diverticular. On the right side, we see the entrance in the esophagus, and on the left side, the entrance in the diverticular. And for performing SET-POEM, it is recommended to use a conform distal cup to facilitate the access into the tunnel. The first step is to perform a submucosal injection, either 1 to 2 centimeter proximal of the diverticular septum, or in a variation technique just above the diverticular septum. Then we perform a mucosotomy of about 2 centimeters length, followed by the entrance and preparation of the submucosal tunnel. And the tunnel is prepared on both sides of the diverticular septums, close to the muscle fibers. And once the bottom of the diverticular septum is reached, we perform the myotomy of the entire muscle fibers of the prepopharyngeal muscle, while the mucosal septum is left intact. And then finally, we close the mucosal incision with hemoclips. So far, we have mostly retrospective data showing comparable results of SET-POEM and conventional septotomy in terms of clinical efficacy, but with a higher rate of adverse events for the SET-POEM technique. But we are still awaiting the results of a randomized controlled trial. And lately, several variations of the original SET-POEM technique have been reported, combining steps of the conventional septotomy and steps of SET-POEM, but data on recurrence rate are so far limited. So thank you very much for your attention.
Professor Messmann, very nice to
Hi.
see you.
Hi,
Please
Roberta.
congratulate with Sandra for this wonderful lecture about all the type of myotomy we can have in the esophagus finally. Now we are able to cut any abnormal and incompetent muscle from the upper esophageal sphincter to the lower one. So very nice. We have some questions. So one is, they are all of them very technical because the presentation is how I do. So what should be the cutoff for CO2 flow pressure? I think they are also mentioning the end-tidal CO2 from the anesthesiologist's point of view.
Let me check what should be the cutoff for
Is
it.
this it?
Oh, really? Honestly, I have no idea. So I thought the first question would be why is not
No, that one is
Sandra
more
Nagl
about the
here?
poem. We already done it.
But Sandra is on holiday, on vacation, so I took over.
Oh,
I'm ashamed.
okay,
I'm ashamed
okay.
that this question on the CO2 flow pressure is I cannot
So-
answer. Maybe you can answer.
No, what can I say is just that if we are if this means the end-tidal CO2 from the anesthesiology,
Yeah.
we have to take care about the delta. So I always check what's the starting point. That could be 27, 28, 32. Who cares? But then I stop a little bit if I reach the point of 45, because means that the anesthesiology needs to hyperventilate the patient in that case. So I stop a bit. There's too much CO2 inside. I let them go down, and then I will start again. But then it depends because the CO2 is under request. So it means that you're using too much CO2 on your bottom.
Yeah.
Let's go to the other one. How? Yeah.
The main take home is if your anesthesiologist gives you a feedback, and then you stop the procedure for 5 minutes and everything is stable, and you can continue.
Exactly.
Yeah.
How far do we go ahead from the junction?
Well, the majority, I would say 2 to 3 centimeters. I think in the very beginning, the people cut it too much, and that was initial data where the reflux was so high. So in our unit, we don't see so much reflux. So we have about 15% or so. That's quite low. we use now the endoflip to guide whether the cutting is enough. We use endoflip also for G-POEM, so it's a kind of monitoring, and perhaps we can avoid overtreatment and to avoid reflux. But yeah, sometimes it's really difficult, and Sandra showed that to find the EG junction very precisely with double endoscope or with staining can be sometimes challenging, even if you have a tissue which is scarred, and so sometimes you get lost. And if the patients are pre-treated, that could be sometimes challenging. But there were no data that this influences the outcome if they are pre-treated or not. So
yeah, I agree. So then we have one more. In Zenka, it is efficacious to perform only septotomy without doing POEM. That I think it means without myotomy, extending the myotomy in the esophagus.
We just do the septotomy.
Yeah. Is it efficient to do it without the myotomy? I mean that you do the septotomy, you don't extend the myotomy in the esophageal side. What do you think?
Good point, but at the end, when we started with a flexible treatment of Zenka, we also did only a septotomy. The first trials were with APC, then with a needle knife. Now we have different knives and scissors, and all these approaches were just to do a septotomy. Our data showed that is very efficient and limited complications. So I don't think there is a need to do a myotomy. No,
yeah.
the result more or less.
Because if we compare also with surgery, who is doing the myotomy is not the open surgery, because in that case they do the diverticulectomy. They remove the diverticulum and they do a myotomy. Otherwise, you have a stricture. But also the otorhinolaryngomatoid surgeons, they are doing a peroral, just the septotomy, because in that case you are focusing on the septum in between the pouch and the esophagus. So maybe we don't need to extend. We'll see in the future if we have more data.
I mean, for deep POEM, sometimes it's necessary and helpful to do a myotomy. In these cases, we also do a manometry before, and if we have the results that there is a high pressure in distal part, then myotomy makes sense versus patients.
Okay, then we have, how do you manage blowout or pseudo diverticulum after POEM? Endoflip could help to direct the management. It's a difficult question.
Yeah, endoflip could help. This is what we have now treated about 50 patients with the use of endoflip.
Okay.
But it's an issue because we see all those patients who have no motility or less motility, the enlarged esophagus, and you do a myotomy, that you see this pseudodiverticulum. Difficult question. Not clear for me whether endoflip is helpful.
The flip could be helpful for the diagnosis, but then the question is different, how to manage it. Will you offer a repoem?
Sorry?
Will you offer a repoem? Will you redo the poem?
These are very frustrating cases, no?
Yes, they are. Yes, they are.
And sometimes we try if we have no other options, but we are aware that this is for sure not ideal, and the patient will still have, in the majority, troubles. Yeah,
we need to understand more what to do. Any interest of POEM in peristalsis disorder without spastic features? Wow, this is very complex.
Any interest of POEM? I don't understand the question.
What
does he mean? Any interest of POEM in peristalsis disorder without spastic disorder?
Even if you don't have any spastic features, the achalasia is a peristaltic disorder. So the type 1 and type 2 is without any spasmodic spasms. So
I mean, a peristaltic disorder could also be in a sclerodermia. So
exactly.
does not make sense to do a poem. And so I think the response is best if you have a spastic disorder. Yeah.
Although there are some data, very few, about scleroderma treated with poem. Very few, but
we never did any treatment of those patients.
no, we neither. Okay, we're out of time, but it has been a pleasure to stay with all of you. You were more than 200, so very nice to have passed 1 hour together and talk about myotomy in the esophageal and gastric side. I want just to mention that we are in the Diamond Jubilee of the ESGE, so we are proud to be here all together, and these are all the different appointments that we have during this year. So please join us in all this, but particularly on the ESGE days that we have in April in Berlin, and we will celebrate all together this great year and great things that as a community we are doing all together. Finally, join our community and join endoscopy in the ESGE. It's very easy and you'll have a lot of benefits in join our membership. Finally, the ESGE fellowship grants, that is one of the benefits that you could have if you join the ESGE. And I hope to see you in face very soon. Just remembering that we'll have the third webinar on February 13th. And we will talk about the prevention of delayed bleeding after EMR. Again, as you can see, great panelists, so don't miss it. And again, thank you for being with us in this hour. Thank you, Professor Messmann. Grazie, Helmut. Grazie, Jan. Very nice to be with you.
Thank you both. Have a nice evening and thank you for joining. Bye-bye.
Good evening. Thank you very much. Good evening. Bye-bye.